Welcome, everybody, to the Expert Perspectives. This is post-conference highlights on MASLD and MASH from EASL. We had a great time at EASL this year. It was in Milan, Italy, and it was a beautiful place, but we also learned a lot. So here are the faculty for this evening. I'm Dr. Kimberly Brown. I'm a professor of medicine at Wayne State University as well as Michigan State University, and I work at Henry Ford Health in Detroit, Michigan. Dr. Sujit Jahardin, who is assistant professor of medicine at Rush University Medical Center in Chicago, and Patrick Horn, nurse practitioner who is working currently at the University of Florida in Gainesville. So we're excited to have you tonight, and we want to thank Novo Nordisk for supporting this CME activity with an educational grant. So here's the program overview. We are looking to provide essentially a CME event. This is provided by the University of Cincinnati College of Medicine, as well as the Chronic Liver Disease Foundation, GHAPP, and this will focus tonight on expert perspectives on MASLD and MASH. This is an accredited feature and will be live streamed and will occur after this liver congress, but also other major liver congresses throughout the year. So if you look at the disclosures here, this is really the planning committee, Lisa Petticone and Rachel as our medical writers, and then the faculty disclosures for myself and Patrick as well as Sujit. They're listed here. You have to understand, hopefully, that this is our disclaimer, that the ACCME standards for integrity and independence in accreditation, they're listed here. Relevant relationships, as you saw before, have been mitigated prior to selecting the faculty and developing the slides. But nothing that we will be presenting will be discussing off-label or unapproved things. This is really conference highlights and data that was presented at EASL. This has been accredited by the University of Cincinnati, and again, in conjunction with Chronic Liver Disease Foundation as well as GHAPP. And the University of Cincinnati designates this activity for a maximum of one Category 1 credit. You, as a physician or provider, should claim only the credit commensurate with the extent of how much you participated in the activity. So here are the educational objectives tonight. When we complete the activity, hoping you will be able to discuss the emerging data on the diagnosis and the monitoring of MASH and MASLD, analyze the current and potential pharmacologic management strategies for MASH, including some of the data from the GLP-1 agonists, and finally to integrate weight loss into MASLD and MASH disease management strategies and see some of the data around that as well. To claim your credits, you are required to complete the evaluation and claim your credits through the online platform. You can use the QR code here and follow the instructions. Ideally, you have taken the pretest, but if you did not take the pretest, it will not prevent you from completing the post-program activities, so please do this. The program evaluation is very important to us so that we can plan future activities and obviously select the amount of credit that you are claiming. So we're going to move into some of the background for MASLD. Many of you have seen this slide before. MASLD, which is very prevalent around the United States and world. Currently, a huge growing crisis. Many people have actually called this an epidemic, but not just here in the United States, but also worldwide. If you look at the prevalence across the world, it's said to be about 2 billion people, about 24% of the population worldwide, which is huge. You can see in the color coding that the prevalence varies from country to country, but many countries have a prevalence greater than 10%. Many of the countries in gray, there are no prevalence data, but you see that many of the countries have darker colors, and those would be areas of higher prevalence. In the United States, when we think about the prevalence here, it's anticipated that it will continue to grow. If you look at the 2018 data, the prevalence was somewhere between 25 and 30%. So about a third of the population in the United States is assumed to have MASLD, which is a huge number. We recognize that MASLD is a progressive process in many of our patients. So if you look at the proportion of patients that have MASLD, so let's say 25%, we recognize that these patients often have associated metabolic factors, including type 2 diabetes, but also a Western diet, other factors, that about 25% of those individuals can progress into the inflammatory component, or what we now designate as MASH. We see fat in the liver, we see hepatocyte ballooning, we see inflammation, we can see fibrosis, and about 25% of those individuals are projected to develop progressive fibrosis over time, and even cirrhosis. And we recognize that cirrhosis is the fourth stage of liver damage. This can be seen either with or without fat and inflammation. Many patients, as they progress to cirrhosis, actually lose the fat within the liver, and we see less of the classic picture that we see in earlier stages. And we recognize that once you have cirrhosis, you're at increased risk of liver failure as well as liver cancer. And when you look at fibrosis changes over time, it is estimated that about one stage of fibrosis change occurs over 14 years in patients who have MASLD, but a much faster one-stage fibrosis over 7 years in patients who have MASH. And we now know that MASH is really the leading cause of cirrhosis in adults in this country. It's the second leading cause, although that is changing for liver transplant recipients on the waiting list. And it is certainly the first cause of wait list for transplant in certain populations, including women as well as Hispanics and Asian. Those patients who have metabolic disease, these are the patients at the highest risk for developing or having MASLD. If you look at the metabolic factors, the majority of patients have elevated BMIs. Up to 90% of patients with BMIs over 30 will also have MASLD. Cardiovascular disease is very prominent. About 70% of patients with cardiovascular disease have MASLD. Well over half, 2/3 of patients with type 2 diabetes will have MASLD, and about half of the patient population with hypertension will have MASLD as well. And we recognize that this is really the liver manifestation of the metabolic syndrome that we see affecting many organs. When we look at baseline fibrosis, we can predict outcomes for patients or mortality, as well as the time to development of severe liver disease. So this is important, right? Why are we trying to identify the patient who has increased fibrosis? Well, if you look on the right first, this is looking at liver-related mortality. And this was a systematic review and meta-analysis of over 13 studies, nearly 5,000 patients with NAFLD, about half of which had histologic NASH, or now denoted MASH. And if you look at the liver-related mortality on the right, you can see that as fibrosis stage increases, particularly once you reach a fibrosis stage 2, the relative risk of mortality increases significantly. But if you look on the left, all-cause mortality increases as well. So fibrosis assessment is critical in this patient population because it can look toward predicting outcomes for our patients. So when we look at the efficacy endpoints, you're going to see some data from EASL. And the FDA has designated two major endpoints for the phase 3 trials for development of drugs, medications to help with MASH. And this is really looking at histology. It's really looking at improvement in liver histology. So the first endpoint is MASH resolution. And by definition, this is resolution of steatohepatitis, as well as no worsening of fibrosis. So resolution of steatohepatitis, no worsening of fibrosis. And on the right, you see fibrosis improvement. So an improvement in one or more fibrosis stages with no worsening of steatohepatitis. So the FDA has really put those two endpoints as critical when we're looking at the development of these medications. So what are some of the approaches for the currently available treatments that we have? Well, you can see on the top left, the attempts to control obesity, right? I told you that almost 90% of patients have BMIs greater than 30. Weight loss is key. Lifestyle, certainly diet and physical activity. Many weight loss medications to try to assist patients. Bariatric surgery, we'll see some data there. But also the GLP-1 receptor agonists. These have been an important addition to our armamentarium for control of obesity. On the top right, we want to reduce cardiovascular risk. There's a two-way street between cardiovascular issues and MASH. We want to treat those cardiovascular risk factors, including hyperglycemia, through the use of GLP-1s or SGLT2s, hypertension control, as well as control of dyslipidemia. And it's important caveat here, statins are actually very beneficial in this patient population. There does not appear to be an increased risk of statin use in a patient population of NAFLD, probably a huge benefit in this patient population. And then at the bottom, targeted therapy for NASH, liver-directed treatment. There's data on vitamin E, except in diabetics. That's the one caveat. Glitazone has data, and now the newly approved resmetirom as well for targeted liver-directed therapy for NASH. So we'll move on and have Patrick present some of the data on emerging data on both the diagnosis as well as the monitoring of MASH.
Yeah, thank you, Dr. Brown, and good evening to everybody. Thanks for joining us. So I'm going to start us off with the first abstract. Again, discussing emerging data on the diagnosis and the monitoring of MASH. Okay, so first abstract we're going to discuss was GS004, and it's the prognostic significance of a change in liver stiffness measurements by vibration-controlled transient elastography. This was a multi-center cohort study, robust 10,920 patients with metabolic dysfunction-associated steatotic liver disease, or MASLD. So the background and the aims. So we know that we need better biomarkers. We know biopsying all these patients is not realistic. So a biomarker should demonstrate not only the diagnostic accuracy to assess liver fibrosis, but it also needs to have the ability to predict prognosis, monitor for disease progression, as well as assess for treatment response. And this is going to become more and more important as more drugs are approved for this disease state. We know that liver stiffness measurement by vibration-controlled transient elastography, or VCTE, as most of us know it by, is a well-established tool to diagnose fibrosis and cirrhosis. But the data on the prognostic implication of the change in LSM remains scarce. So the methods for this particular study was they included data of patients with MASLD who had undergone serial VCTE examinations at 16 centers, including in Europe, the US, as well as Asia. And I want to note that 14 of those centers were actually prospective. Primary outcome was liver-related events, or LREs, and they define that as hepatocellular carcinoma, or HCC, or hepatic decompensation, such as ascites, variceal hemorrhage, or hepatic encephalopathy. And these are their results. We'll kind of go through this. It's a busy slide, but we'll break it down. Basically, they took the kilopascal measurements and they broke the patients into categories of low, intermediate, and high. Low being a kilopascal score less than 10, intermediate was 10 to less than 15, and then high was greater than or equal to 15 kilopascals. So as I mentioned, there were 10,920 patients with MASLD included in this study, and they had at least 2 VCTE examinations. And you can see between the first and the second, the interval time between those was around 15 months, and that ranged anywhere from 11 up to 28 months in duration. And then between the second and the third, you saw a larger interval of time in between of 34 months, but again, ranging anywhere between 12 to 56. There was a little bit of overlap there. At the second VCTE reading, what you see is that 85.9% actually had a stable risk category, so didn't change from their baseline. And they saw 5.3% actually progressed from one stage to the next, or classification to the next. And then you also had over 8% that actually improved, close to 9% that actually improved and went down in classification. At the third VCTE, what you saw was the development of these liver-related events. So 1.1% developed a liver-related event. 55 of those were hepatocellular carcinoma, and another 81 of those was decompensated cirrhosis. When you break it down a little bit deeper and you really look at both the low risk and the high risk groups, what you see in the low risk group is 0.9 per 1,000 patient years stayed the same. They remained in the low risk category. So they did not progress into intermediate or high. Then you saw about 4.1 per 1,000 person years actually advance from low to intermediate. And then a higher number of 8.5 per 1,000 person years actually advanced from low risk into the high risk category. Looking at the high risk category, what you saw was some did regress down to low risk category, 7.8 per 1,000 person years. You also had a fair number, 19, or 19.4 per 1,000 that regressed from high to intermediate. And then the majority, though, stayed in that high risk at 38.7 per 1,000. So what the investigators concluded is that changes in liver stiffness measurement over time is predictive of liver-related events, and that we can use serial liver stiffness measurements through, in this case, using VCTE to monitor disease progression as well as regression in patients with MASLD, which again, I think is very important, knowing that it's unrealistic to perform liver biopsies on all these patients with MASLD. And with that, I'll open it up to discussion.
Thanks, Patrick. This is really interesting data because the majority of the non-invasive testing data we have are to kind of risk stratify patients right at the beginning of therapy. Very, very limited data on the utility of these to monitor patients over time. But to your point, that's what we're going to use. So how do you think this data is going to impact, how we monitor these patients? I mean, we need some guidance, right?
Yeah, I would agree. I mean, I think I think some of that remains to be seen, right? I think this highlighted that, at least within this cohort, and again, it was a large cohort of patients, it does appear that at least VCTE seems to be a viable option, and there are ways to sort of monitor for disease progression or regression or even stability in some cases with this patient population. But I think it's an evolving science, and to your point, Dr. Brown, I think again, this is where we're going. It's unrealistic to think that we're going to be able to get liver biopsies on all of these patients for various reasons. And so we're going to have to get more data on these non-invasive tests, whether it be VCTE, whether it be serum markers, et cetera, to find, what is the best fit and what does it all mean exactly. But I think this is definitely a good start to show that it appears, at least in this cohort, that VCTE does have validity in monitoring for progression or regression of disease, and we just need, I think, build on it from here.
Yeah, no, it's great. Sujit, I'm often asked, you know, when we give these talks, somebody, you know, they don't have a fiber scan anywhere near them, sometimes not even, you know, within 100, 200 miles. So what, you know, we have to have something to monitor these patients. What are you recommending?
Yeah, it's a great question. And of course, the answer is to get a magnetic resonance elastography, which is even harder to find.
Yeah.
But I think that one thing that we're seeing good data for is the change in the FIB4 tests. You know, so I actually think that that probably has better data than just FIB4 in general. So something that we can use that's readily available. You know, in talking to people that make the ELF test, the enhanced liver fibrosis test, the data isn't yet great on looking at that as a serial marker to see, but I think it has potential. It just hasn't, because it's not as, was not as readily available as the FibroScan that was present in all of our hepatology clinics. I think that that has potential, but I also think that there's some of the newer Agile 3 scores and things like that that can be used as proxies for essentially clinically significant portal hypertension, which is what we're seeing here. I thought one of the interesting things from the study that Patrick demonstrated was that we had a similar number of liver-rated events if you moved from low to high as if you moved from high to low. So it really makes you wonder that, you know, that person that goes from high to low, you shouldn't necessarily feel that comfortable with unless they stay in that category, I suppose.
Yeah. Yeah. No, that's an important thing. I think I'll look forward to more data like this. But so Sujit, do you want to move on and show us some of the data for some of the medications?
Yeah, thank you so much, Dr. Brown, and thank you to CLDF and GHAPP for organizing this event. Thank you for spending their dinner time with us. It's an interesting thing to talk about around dinner time. But I am excited to talk about this data. I'm just excited to be able to talk about MASH data in general these days. Been in this field for probably about a decade since finishing training. And when I think about MASH drug development, I think a lot about my favorite football team, which is the Buffalo Bills, about how we went through a period of time of just what seemed like futility. A lot of really hard work and brilliant studies that were created, but we were disappointed by some of the outcomes. But now here we are seeing studies come out where I just feel like we're stacking wins and really seeing major changes in the field, and it's exciting to be a part of. So the first study I want to talk about is GS006. There is a parallel New England Journal manuscript that we'll talk about. This was presented by Dr. Sanyal, and it is a glucagon and GLP-1 receptor dual agonist. The molecule is called survodutide, and we were looking at its role in improving liver histology in patients with MASH. So as I mentioned, the data was published in the New England Journal around the same time it was presented at EASL on June 7th, 2024. The data from the EASL abstract differs a little bit from the New England Journal article. So we're going to be presenting data from the New England Journal because that's what most people will have access to. But if you go to the supplementary data from the article, you'll probably see some of the data that was seen in the abstract study, or sorry, in the EASL abstract. So this is a dual agonist of the glucagon receptor and GLP-1-like receptor. And the rationale behind the creation of this molecule is that GLP-1 receptors we know are great at reducing appetite, reducing cravings, you know, improving the glycemic control from a extrahepatic effect. But the benefit of a glucagon receptor agonist is that it can actually stimulate the metabolic pathway within the liver, thus allowing for increased energy utilization and potentially increased lipolysis within the liver. So that's the idea behind combining these two molecules to be used. So this was a phase 2 trial. 293 patients were enrolled. They had to have biopsy-proven MASH, and required a NAFLD activity score of 4. So just briefly talking about that for people that are not familiar with it. The NAFLD activity score is a composite of the histology. So looking at the steatosis score, the inflammation, fibrosis, and ballooning, or markers of cell death. So that gives you a composite score, and they had to have a score of at least over 4. All patients had overweight. And they received either a once-weekly injection of one of 3 doses of survodutide or placebo. Now, the study was created in 2 phases. The first 24 weeks was a rapid dose escalation where they tried to get patients to the dose range that they were assigned to during randomization. And then that was followed by a 24-week maintenance phase where they were held at the maximal dose tolerated. The primary endpoint was histologic improvement in MASH with no worsening of fibrosis. Now, I do want to point out that this is different than some of those FDA-approved endpoints that were noted by Dr. Brown. Here, we're talking about an improvement in the NAFLD activity score by greater than 2 points with no worsening of fibrosis. So it's not the same as NASH resolution, which is what we've talked about in other studies. But it's a phase 2 trial. So I think that in order to get to the next stage, we'll be talking about NASH resolution. Some of the secondary endpoints included a decrease in liver fat content by 30% by MRI-PDFF and a biopsy-proven improvement in fibrosis by at least 1 stage. And again, that's a little bit different too. It's not improvement in fibrosis without worsening of MASH. Again, like I said, in the supplemental data, they do have all those FDA-approved endpoints. So that's something that people can look at, and the data is still good for those. So looking at the data now, survodutide was able to achieve its primary endpoint of improvement in MASH with no worsening of fibrosis across all dose treatment categories for survodutide. So the response rate was from 43% to 62%, and it wasn't quite dose responsive. This was 47% in the lowest dose and 43% in the highest dose and 62% in the middle dose. But this was all compared to 14% with placebo. Looking at some of the secondary endpoints, there was a decrease in liver fat by 30% or more in 57 to 67% of patients that were on survodutide. And looking at improvement in fibrosis by 1 stage, about 35% of patients across the board had an improvement in fibrosis by at least 1 stage. I want to mention that the data that's presented in the New England Journal article is the modified intention to treat population. So what that means in this study was that, as I mentioned, patients were in a dose escalation period and then in a maintenance phase. So not everybody that was assigned to 6 milligrams at randomization was able to achieve 6 milligrams. They might not have tolerated it. But those patients, maybe they got to 4.8 milligrams, or maybe they just got to 2.4 milligrams, but they were still included in the 6 milligram group for this analysis. So not everybody that's represented in the 6 milligram group necessarily got to that dose range. In the supplemental data, there's data representing the actual dose range that people got to and what the outcomes are. So in that supplemental data, you'll see that, especially for the highest dose ranges, the people who actually got to the highest dose ranges of survodutide had a modest improvement in some of these outcomes. They also present the data for people who had paired biopsies. This data includes people for which paired biopsy data was missing, and those patients were considered non-responders. So in that supplemental data, you see that there is a modest improvement in the outcomes for patients that had paired biopsy data. Important point here is that the AEs were frequent kind of across the board, including placebo, but there were more AEs, specific AEs with survodutide compared to placebo, especially nausea, diarrhea, and vomiting. About 20% of patients had to discontinue medication or had to discontinue the study drug in the survodutide groups across the board. So that's something to consider. But serious adverse events were similar between survodutide and placebo. Moving on to the next abstract, this was looking at tirzepatide, a molecule that's currently approved for obesity and diabetes for treatment of MASH in patients with liver fibrosis, and Dr. Lumba presented this trial, the Synergy NASH trial. It's a phase 2 trial. So similar to the survodutide trial, this was published around the same time in the New England Journal of Medicine. The results in the abstract are different from the journal article, so we'll talk about the journal article data. And again, we were looking at the efficacy and safety of tirzepatide, and this is an agonist of GLP-1 receptor as well as the glucose-dependent insulinotropic polypeptide, or GIP. We know the profound effects this can have in glycemic control as well as weight loss, and we were looking at its effect in patients with MASH with moderate or severe fibrosis. So that's an important point. In this study, only patients with MASH with stage 2 or 3 fibrosis were included, so no stage 1 fibrosis, similar to the like the other trial. And patients were randomly assigned to receive once-weekly subcutaneous dosing of 1 of 3 doses of tirzepatide or placebo for 52 weeks. It was a multi-center, double-blind, randomized, placebo-controlled trial. The primary endpoint in this trial was, in fact, MASH resolution without worsening of fibrosis at 52 weeks. Just a little bit about what they mean when they say MASH resolution. That means either the steatosis grade went to 0, so there was complete resolution of steatosis in the liver, or there was still steatosis, but it was bland steatosis. So the inflammation score went to 0 or 1, and the ballooning score had to be 0. So that's what we defined as MASH resolution. A key secondary endpoint is the improvement in fibrosis by 1 stage without worsening of MASH. So this is looking at the data from the phase 2b study, and you can see that there's actually a nice dose response of tirzepatide in inducing MASH resolution without worsening of fibrosis. 44% in the lowest dose category, up to 62% in the highest dose 15 milligram category. We saw that, I think, if I'm not mistaken, 95% of patients were able to achieve the 5 and 10 milligram dose when they were escalated, and it was a little bit lower, maybe closer to 85%. I don't remember the exact data in the highest dose category. Looking at and this was compared to 10% of patients achieving this endpoint with placebo. Looking at the fibrosis data, about 50% of patients across all dose categories achieved fibrosis improvement by 1 stage versus only 30% with placebo. The most common AEs in the tirzepatide groups were the GI side effects that we seem to see with all of our GLP-1 based therapies. Most were mild and moderate in severity, and there weren't very high rates of dropout due to AEs. I think it was 0 in 1 category, 8 in 1 category, 4 in 1, but placebo was 4. So not huge rates of dropout, and the gastrointestinal events were mild or moderate in severity. Moving on, the next study, denifanstat is a fatty acid synthase inhibitor. This is not, the classic MASLed molecule that you hear about at your kitchen table every day. This is one that's, for me, a little bit more under the radar, but it's exciting because I think it's a really potential important molecule to have in our armamentarium in fighting MASH. So Dr. Lumber presented data from the FASCINATE-2 trial. Some of the phase 2a trial, I believe, was presented last year at EASL. So this is looking at, that was 26 weeks data, and this is looking at, sorry, the 26-week data was presented at EASL last year by Dr. Harrison. And now this is the phase 2b trial looking at the 52-week data. And this, little bit about this molecule. So it's an interesting molecule. It's an inhibitor of fatty acid synthase. Fatty acid synthase is expressed in hepatocytes, stellate cells, as well as Kupffer cells, as well as immune cells. So in the phase 2a trial, as well as in preclinical models, it's been shown that inhibition of fatty acid synthase can reduce hepatocyte steatosis and blocking de novo lipogenesis, reduced inflammation via its action on immune cells, and decreased fibrosis via action on stellate cells. So a really interesting molecule that can really attack multiple components of MASLD. Again, thinking now more inside the liver rather than globally for metabolic syndrome. But of course, this molecule has global effects as well. So this trial was a phase 2b, multi-center, double-blind, randomized, placebo-controlled international trial. And there was 168 patients in the intention to treat group with stage 2 to 3 MASH, randomized 2-to-1 to once daily oral denifanstat, 50 milligrams or placebo. And what they found was that about in the intention to treat population, which included all patients, was 38% of people were able to achieve the primary endpoint of an improvement in the NAFLD activity score by 2 points without worsening of fibrosis, compared to 16% with placebo. The modified intention to treat population was the group where they had paired biopsies for everybody. And so you can see there's a little bit of an increase in response, up to 52% in the denafanstat group versus 20% in placebo. When they looked at the secondary endpoint of MASH resolution, not just NAS improvement, but MASH resolution without worsening of fibrosis, about 26% of patients were able to achieve that versus 11% with placebo, and that number went up a little bit in the modified intention to treat population. They also looked at improvement in liver fibrosis by one stage with no worsening of MASH. Again, this was at week 52. And we saw about 41% of patients achieving this clinical endpoint versus 18% with placebo. So this is an improvement from the 26-week data. So definitely encouraging. And I'm really interested to see how this gets incorporated if it continues to show this positive data into our armamentarium. One important thing with the FASCINATE study and denafanstat was some of the AEs. About 35 to 40% of people had AEs related to the study drug, and that included placebo. And serious adverse events were slightly higher in the denafanstat group. And there was a decent amount of drug discontinuation due to treatment emergent adverse events, about 20% of patients. The big one that they saw in this study was hair thinning, which is interesting because if you look down here in the previous study, less than 2% of patients experienced hair thinning. They did notice that the hair thinning stabilizes at a 2 to 4 week dose hold and that it was reversible. But just something to learn more about as we learn more about this drug moving forward. Lastly, we'll talk about efruxifermin. This is an FGF21 molecule. We saw the initial data at 26 weeks, and now we're starting, 26 weeks, and now we're starting to see the 96-week data. So the HARMONY study had previously met its primary endpoint of a one-stage improvement in fibrosis with no worsening of MASH in patients with stage 2 or 3 fibrosis receiving once-weekly efruxifermin. And about 40% of people achieved that endpoint versus 20% with placebo after 24 weeks. Now we're looking at the longer data, right? We're looking at 96 weeks on this therapy that showed promise. And efruxifermin, FGF20 molecules, there's a variety of different types. There's pegylated versions. This one is an FC fusion protein where FGF21 is bound to the FC domain of an immunoglobulin molecule. So pretty impressive data here. So looking at improvement in fibrosis without worsening of MASH, we see that at the lower dose of efruxifermin, 46% of patients are able to achieve this endpoint versus 75% of patients at the higher dose. And that's compared to 24% with placebo. They even looked at a 2-stage improvement in fibrosis, and that was achieved in 31 to 36% of patients on efruxifermin versus only 3% with placebo. So much harder outcome to look for. MASH resolution occurred in 57 to 62% of patients on efruxifermin versus 24% with placebo. And when they looked at the composite outcome of MASH resolution and improvement in fibrosis, that was showing an improvement of about 42 to 54%. Again, it seems like if we're going to make clinical inroads on MASH, we're going to have diarrhea and nausea, because I think that all of our medications seem to do that. So that was the most frequent drug-related AE, was diarrhea and nausea, occurring diarrhea in about 35 to 40% of patients, and nausea in about 30% of patients on efruxifermin. But again, discontinuations due to study drug were relatively rare. But this is really exciting, right? As we start to think about these therapies, we're starting to really see things where we can make disease-modifying interventions, and not just with weight loss, which is the foundation of my core in terms of improving metabolic health. But now we're seeing drugs that can also have outcomes similar to bariatric surgery, to weight loss. And so another aspect to our armamentarium. So happy to discuss this further.
Great, thanks. That's really, there were a lot of exciting presentations, I think, at EASL this year, as evidenced by the fact that they all seem to have gotten into the New England Journal, right? Simultaneously.
Same day, yeah.
Yeah, same day. So, one of the questions that I'm often asked is, there's been a lot of talk, obviously, about how weight loss affects the ability of these medications to work. And so can I ask you what your thoughts are? I mean, do all of these medications work by, having us lose weight? Do some of them work differently? When you look at the data and really dig into it, you know, if you lose weight, is that who responds to these drugs? Is it really the weight loss? What do you think about that?
Yeah, I think it's a really interesting point, because if you look back at some of the original semaglutide data, the phase 2 data, where patients had greater than 10% weight loss, I think it was about 12% weight loss. And then you look back at some of the traditional lifestyle-based weight loss studies where people who achieved 10% weight loss had those who had fibrosis to start with had an 80% of them had improvement. It really does raise the question of, is dietary weight loss and lifestyle-based weight loss, where you're modifying your exercise, you're modifying the types of foods you eat, the processed foods you eat, is that the same as taking a medication and inducing weight loss that way? Just even as something as simple as a GLP-1 that causes reduction in appetite and reduction in cravings, does that fundamentally change the types of foods you're eating, even if you're eating less of it? So I don't have enough data to say this strongly. I do have a feeling that lifestyle-based weight loss is more effective or more beneficial. I think it's no doubt that it's more beneficial in controlling multiple aspects of metabolic syndrome. But I definitely think there's a role in medication-related weight loss improving outcomes for MASH. And the reason I bring that up is that as a person that does obesity medicine extensively myself, it's not easy, right? And so we need something to help us along the way with weight loss. And a lot of these medicines really target the aspects of behavioral weight loss that are so difficult: cravings, hunger, etc. And so I think it has to be in conjunction. And I think it's also more about, the reason I get so excited about talking these molecules is that we're now talking about molecules that involve the metabolic syndrome, not just focusing on the liver. And so when we take that step back and treat metabolic syndrome, including obesity, including cardiovascular risk, and glycemic control, then maybe we'll be making bigger inroads. And maybe that's why these medicines work so much better, is because they're not just treating the liver, they're also treating some other aspects of metabolic syndrome.
There is a question here in the chat regarding the data on survodutide, which was there data that you had looking at discontinuation rates with that medication? Seems like a lot of patients on GLP-1s don't tolerate it well. What was the discontinuation rate with that molecule? Do you know?
Yeah, sorry, I mentioned it in the presentation, but it's only in the actually it's not in the supplemental, it's in the New England Journal article. There was high rates of discontinuation. 20% of people, if you look at a composite across the board for all doses of survodutide, 20% of people had treatment discontinuation due to adverse events. Now, I don't know that it's something specific to GLP-1s, because if you look at the tirzepatide data that also contains a GLP-1, the discontinuation rate was much lower. And, there's been a lot of press in the data, in the literature about, a lot of press about discontinuations with GLP-1s in general. I think it's important that we make distinctions between discontinuation versus due to intolerance versus discontinuation due to lack of availability. So some of the stuff in the press is just they stopped taking it. Well, why did they stop taking it? I think it's also really important for us providers to give patients anticipatory guidance when we start these medications, that you have to change the way you eat. You can't eat when you're not hungry. You can't eat big meals. And that's an important point to help people stay on medications. But there's no denying the fact that there was a 20% discontinuation rate in the survodutide study.
Yeah. Well, thanks. Well, I think Patrick, why don't we move on to the last couple of abstracts, and then we'll have a few minutes to answer any additional questions that people have in the chat.
Sure, sounds good. All right, so the next abstract I'm going to take us through was from Dr. Mayhofer's group. And this was actually a late breaker poster at EASL, and kind of builds on what we had just kind of been talking about around GLP-1s and having positive impacts in other parts of the body, not just within the liver. So this was looking at semaglutide and improvements in cardiovascular outcomes in patients who were at high risk for having MASLD or MASH. And this was a subgroup analysis of the SELECT trial. So just some background. I think we all probably know this, but cardiovascular risk is increased in people living with MASH. Again, I think most of us know that. And non-invasive testing such as FIB4 are useful in staging these patients with fibrotic MASH and predicting overall both cardiovascular as well as liver-related mortality. And Dr. Brown, you kind of touched on this at the beginning of the program. The SELECT trial was a cardiovascular outcomes trial, and it included patients with BMIs greater than or equal to 27, as well as those with established cardiovascular disease, but without diabetes. And it was looking at those treated with a GLP-1. In this case, it was semaglutide. And what they found is that within the trial, these patients had a 20% cardiovascular risk reduction compared to those receiving placebo. And so what they wanted to look at is a sub-analysis of, do these cardiovascular effects, do we see these cardiovascular effects in the subgroup of patients who have a high risk for MASH? And that was defined based on a FIB4. So again, SELECT, it's a multi-center randomized double-blind placebo-controlled event-driven trial, robust enrollment over 17,000 patients aged greater than or equal to age 45. Patients were randomized 1-to-1 ratio of either receiving once weekly sub-Q semaglutide at 2.4 milligrams versus a placebo. And this was in addition to, as we just kind of talked about, standard recommendations of care, and that includes diet, exercise, et cetera, for cardiovascular disease. The subgroup analysis, their primary composite endpoint was looking at the major adverse cardiovascular events, or MACE, and those are non-fatal myocardial infarction, non-fatal stroke, and CV death. And this was performed in patients with an increased MASH risk, and the way they define that was a FIB4 greater than or equal to 1.3 if you were less than 65 years of age, or a FIB4 greater than or equal to 2 if you were greater than or equal to 65. And then in addition, there was a second subgroup where they took all ages and anyone who had a FIB4 greater than 2.67. And what they did was this was identified again this was identified through medical history, co-medications, and patients with a cause of liver disease other than MASH they excluded. So these were purely MASH patients. So here are the results. So within this cohort, they had 3,665 patients. That was about 20.8% of all of them, aged less than 65 with the FIB4 greater than or equal to 1.3, or over 65 or older, I should say, with a FIB4 greater than or equal to 2 that were included. And this is what we saw with the primary cardiovascular endpoint. So within the semaglutide group, there was 140 of about 834 patients, so about 7.6%. And then there was about 176, or about 9.6% in the placebo group. Within the subgroup, these are the patients with, regardless of age, just had a high FIB4 over 2.67. They had 475 patients with suspected MASH and advanced fibrosis based on that FIB4. What they saw is there were 22 cardiovascular events in 235 patients treated with the semaglutide at 2.4 milligrams versus 35 events in the 240 placebo-treated patients. So what they concluded was, in line with the primary analysis from the SELECT trial, the use of semaglutide, in this case, it was just 2.4 milligrams in a subgroup of patients who were considered high risk for having not only MASH, but fibrotic MASH, had a 21% reduction in MACE outcomes compared to placebo. And this just shows it graphically. So again, if you look at the overall populations and you look at the 2.4 milligram semaglutide group versus the placebo, you saw a reduction in cardiovascular events of 7.8% with the semaglutide group versus 9.6% in the placebo. And when you break it down and look at the specific sort of this risk for MASH population and advanced fibrosis, you saw even a larger disparity where you had a reduction down to not only 9.4% of patients who received semaglutide had a cardiovascular event versus almost 15% in the placebo group. So the difference there, again, a reduction of about 21%. And I think that's important because we saw earlier this year, CMS came out and actually put out in their guidance that semaglutide should be used to reduce cardiovascular events in patients who have cardiovascular disease as well as have obesity. So this sort of just highlights that point and shows that there is definitely a role or appears to be a role within this MASH population as well. So the last abstract I have to present actually shifts gears. So we're going to shift away from medication and we're actually going to look at surgery. And we mentioned it briefly, but this one specifically looks at surgical intervention, not medical intervention. So this was an abstract that looked at 15-year outcomes after metabolic surgery in patients with compensated cirrhosis due again to MASH. So just a quick background. At the time, there was no therapy shown to reduce the risk of serious adverse outcomes in patients with compensated cirrhosis due to MASH. This was a large cohort within the Cleveland Clinic Health System. 36,912 liver biopsies were performed between a period of 1995 and 2020. These were adult patients with obesity and compensated histologically proven MASH cirrhosis. So Child-Pugh-A with a sodium meld less than or equal to 10 is what they classified. And they were selected for this observational study that was named SPECIAL, which is surgical procedures eliminate compensated cirrhosis in advancing long-term. It was a doubly robust estimation combining overlap weighting and using a multivariate variable adjusted Cox regression analysis to utilize to compare time to incidence of major adverse liver outcomes, MALO, defined as a first occurrence of a decompensated event. So ascites, variceal hemorrhage, hepatic encephalopathy, HCC, also liver transplantation, and all-cause mortality between patients who received metabolic bariatric surgery versus those who received sort of standard of care, usual. In here they say usual care. The second composite endpoint was the progression to decompensation, defined again as the first occurrence of ascites, variceal hemorrhage, or hepatic encephalopathy. So busy slide, but we'll kind of go through it. So the study analyzed 168 patients, most of those being female. This included 62 patients who received metabolic surgery versus 106 who were in the non-surgical control group. Again, all had compensated MASH-related cirrhosis, biopsy proven. The follow-up was over a 25-year period. The mean follow-up was 10 plus or minus 4.5 years. The characteristics you could see, the mean age was 54.4 years. BMI was almost 43. FIB4 scores were around 2.1. Pretty well preserved liver synthetic function, albumin of 4.1, a bilirubin of 0.6, and a fairly normal platelet count actually for a cirrhotic population. Each group had almost 85% type 2 diabetics, and almost 80% had an Ishak stage 6 on liver biopsy, as you would expect. So when you look at the incidence of the MALO or MALO, I'm not sure exactly how you pronounce it, but at 15 years, it was about 21% in the surgical group compared to 46.4% in the non-surgical group. So significant difference there. So that's an adjusted absolute risk difference of about 22%, pretty significant. When we look at the cumulative incidence of progression to decompensated disease over the same 15-year period, the surgical group was about 15.5% that occurrence versus almost 31% in the non-surgical group. So again, an adjusted difference of almost 21%. And then the mean total weight loss over that time period in the surgical versus non-surgical group was 26.6% in the surgical group, so almost a third, versus less than 10% in the non-surgical group. So metabolic surgery, when you compare it to a non-surgical management, at least in this study, was associated with a significantly lower risk of incidences in these patients who came in as compensated MASH-related cirrhotics and also had obesity. So I think it's just another tool in the arsenal, if you will, to consider in particular patient populations when we're talking about ways to modify, reduce risk, and improve outcomes especially in this case in cirrhotics. And I'll open it up for discussion again.
Thanks, Patrick. You know, historically, many bariatric surgeons have avoided bariatric surgery in patients with cirrhosis. So I think this is really impressive data, although I think, you know, if you look at the platelet count, none of these patients had, you know, portal hypertension. So that may be the difference. But one of the questions I have for you is, you know, the nearly 30% weight loss that you see with bariatrics, some of the medical therapeutics are getting close to that, right? In terms of overall percentage weight loss. I mean, how do you choose, you know, when you see a patient and you're trying to influence outcomes, how do you advise them in terms of diet and exercise, medical therapy, bariatrics?
Yeah, I think that's a tough one. I mean, for me personally, I think I reserve surgical intervention as sort of my last resort, if you will, especially with the advent of the GLP-1s and other therapies like that. Those are kind of my first go-to. But what I would say, and this kind of builds on the earlier discussion we had too, with all these drugs, you know, potentially becoming available in the future, is the treatment, and whether it's bariatric surgery or whether it's a medicine. I think that's just one part of the whole equation. I always begin the discussion, whether I'm starting a GLP-1 or I'm thinking about referring somebody for bariatric surgery, it's a three-pronged approach at least. So it's, yes, there may be a medicine or a surgical intervention involved, but it's also got to be diet, and it's got to be exercise, and it's got to be, as we mentioned earlier, you know, the types of food you're eating. It's not just about the amount, it's the type of food you're eating, and it's also about the level of activity. Yeah, these therapies, you're going to lose some weight, whether you're on a GLP-1 or you're getting bariatric surgery, you're going to lose some weight, but where you're going to maximize the benefits, not only short-term but long-term, is to incorporate the diet and the exercise and change those modifiable, you know, lifestyle factors, if you will. And that's where I've seen the most benefit in patients, is when they can really achieve those three things. And as they start to lose weight and they start eating better, they start feeling better, and then they're able to start moving more, and then they can really start to maybe incorporate more of that exercise.
Yeah. You know, Sujit, there's an interesting question in the chat around whether you think these medications are going to work in patients who are not obese, right? Is there efficacy in some of these medications in patients who either don't lose weight on them or are not overweight to begin?
Yeah, so it gets to the question of the lean NASH population, or the lean MASH, sorry, population. It's old habit, hard to break. So you know, MASH, as we alluded to, is a component of the metabolic syndrome, and metabolic syndrome is more than just obesity, right? So there's NHANES data suggesting there's different metabolic profiles of patients with MASH. So I can't remember exactly the first author, I apologize. But basically, when they looked at NHANES data, they saw that there was one population that was predominantly female with high levels of obesity and diabetes, another population that had dyslipidemia, were more male, and higher rates of CKD. So I think that if we have MASH and it's a lean patient, most of the time, not all of the time, most of the time there is still metabolic disarrangement. So they still have diabetes or pre-diabetes, they still have dyslipidemia or hypertriglyceridemia. And when I looked back at the metabolic changes that occur with some of the medications that we just talked about, survodutide, we know this with semaglutide, and certainly with tirzepatide, there was a marked improvement in triglycerides, right? And so, we know that some of the data surrounding resmetirom shows improvement in lipid profiles as well. So I think that gets to the fundamental question of, do you treat the liver, do you treat the metabolic syndrome? Well, the answer is really you do both. And so if you have a patient that has metabolic risk driving their MASH, you want to choose whichever agent targets that metabolic risk. So stop the driver of the MASH, and hopefully you'll stop the MASH at the same time, regardless of whether that driver is obesity or something else.
Thanks. Well, we're at the top of the hour, so I just really want to thank both of you. Great discussion, really great abstracts, exciting data coming out. And thank you to Novo Nordisk, thank you to CLDF and GHAPP, thank you to the sponsors, and hope everybody has a really good night. Thanks a lot.